Hello and welcome everybody to the Fibro-Fix Summit. I'm Dr. David Brady, your host for the summit and author of the book, The Fibro-Fix. And today, as our expert for this interview, we have a very respected colleague of mine and a very good friend of mine who I've known for a very long time, and I'm really excited to have her on the summit because of what's in her brain, basically. And she's a great person as well. It's Dr. Kara Fitzgerald. And Dr. Fitzgerald, after her naturopathic medical training, completed a postdoctoral residency in nutritional biochemistry and laboratory science at Metametrics Clinical Laboratories. She authored and edited case studies in integrative and functional medicine, a wonderful book that many of us integrative and functional medicine doctors utilize all the time. She was also a contributing author, as I was, in the textbook Laboratory Evaluations for Integrative and Functional Medicine, another staple of our field. And also the Institute for Functional Medicine's textbook for functional medicine. She has been published in numerous peer-reviewed journals, and she blogs regularly for professionals and patients and consumers on her wonderful website, drkarafitzgerald.com. And she'll tell you more about that at the end of our discussion today. Dr. Fitzgerald is one of the few functional medicine experts that has the privilege actually of being on the faculty for the Institute for Functional Medicine, and she maintains a private practice in functional and integrative and naturopathic medicine in Sandy Hook, Connecticut. So that being said, welcome to the Fibro-Fix Summit, Dr. Fitzgerald.
Thank you, Dr. Brady. It's great to be here with you.
Well, I know you're really busy in clinical practice, but
right.
And all your other stuff that you do, flying around the country like me, trying to talk to a lot of our colleagues and teach them how to do a lot of the things that we do. And you're real expert. You have many expertises, but where you really shine is really understanding this whole idea of integrative and functional and metabolic testing. All the testing that the kind of physicians that do what we do rely on every day, and you really know the ins and outs and the nitty-gritty granular details of that stuff and how to clinically apply it. And when we're dealing with patients who have been diagnosed with fibromyalgia, or maybe they think they have fibromyalgia, maybe a neighbor told them, maybe WebMD told them, maybe a rheumatologist told them, who knows? Many of them have a whole bunch of different things wrong with them that are not really classic fibromyalgia, not this centrally mediated pain processing disorder that, in the brain where they just misinterpret sensory input as pain, and they don't have this central sensitization kind of disorder. Some do, but some don't. Some have other metabolic conditions that get mislabeled fibromyalgia. And if it's mislabeled, as they say, proper diagnosis is half the cure. You don't want them thrown on Lyrica or something like that when they really don't have classic fibromyalgia.
Right.
There's a lot of downside, not a lot of upside. So we want to talk about all of these other metabolic things that get mislabeled as fibromyalgia. So that's where I wanted to bring you in, because you can talk about a lot of these different available tests to kind of weed through this, and not that the listener who's maybe afflicted with a condition like this will know all of the things you're talking about, but at least it gives them an idea that there's things out there, and maybe they can take it to their provider or find a functional medicine doctor who can help them work through this.
Yes.
So, I'm sure you see lots of patients that come in and either say they have fibromyalgia or they've been diagnosed with fibromyalgia. What is your thinking on, the things you need to look at to try to really differentially diagnose them? They answer that question. Do they really have it or do they not? And if they don't, what do they have? What are your go-to kind of tests that you want to talk about first?
Right. Okay. That's a great question. And before I jump in, I just want to say congratulations on your book.
Thank you.
And, you're a real pillar in this arena for patients and clinicians alike. I mean, you've done due diligence in the literature. You've published a lot on this topic. Most of us are looking at your publications to guide us through the differential diagnosis. And so I really have to give you a strong shout out for, leading the way. And I'm thrilled that you've got this book for patients because it's going to be incredibly useful in turning people's lives around. So
Thank you.
with that, you're welcome. I'm just really excited for you because I love the work you've done in really dissecting, what's this true centrally mediated pain process, which, you've just done such good work in here. And where are we looking at other functional medicine or functional disturbances? So
Right.
yeah. So let me talk about what I'm thinking about with regard to labs. I think, you remember, David, I used to work at a tertiary care pain center where I
Yes.
saw endless amounts of fibromyalgia patients who were being managed on opiates and all of the, the cocktail of medications you've just mentioned. So I've had a chance to really kind of dive into this from a laboratory perspective with these patients. And my conclusion is that we have to, take a really careful history to guide us in the labs, because there's a lot of possible underlying imbalances that can end up presenting like fibromyalgia.
Right.
So we want to do a really super careful history. And then from that, we will determine what panel of labs need to be looked at. And for me, things will include organic acids, which we'll talk about, looking at their ability to make energy in the mitochondria, looking at nutrient imbalances, looking at their ability to detox. I'm always looking at food reactions, allergies, food sensitivities, food intolerances. I'm thinking about toxins, metals, mercury, lead, particularly mercury, but any of the metallotoxins, as we call them, or even organotoxins, plasticizers, those kinds of things. So sometimes that's important. Neurotransmitter imbalances, going back to thinking about organic acids, infectious diseases, that can play a role here.
Especially where you are in Connecticut.
Yeah, right. Both of us, we're undoubtedly seeing this. And, gut health, dysbiosis, imbalances in our ability to digest and absorb our foods and so forth. So the potential to cast a very wide net with this patient, with folks diagnosed with fibromyalgia is there. And, a careful history will really help us zero in on the evaluations we need to make.
Yeah, that's a great point, because, the basics of medicine, right? It really starts with the history. I mean, most of your diagnosis is in just talking to the patient. Even today, with all of our high-tech diagnostic labs and imaging and things like that, you really start the whole thing by just talking to the patient. And fibromyalgia is not an exception to that. In fact, it's even more important, because the odds are, if the patient doesn't have pain all over the body, it can't just be in a couple of places. It can't just be in the neck and in the low back. It's got to be everywhere. Right. It's got to be in the soft tissues, not the joints. And then they really have to have these concomitant symptoms like persistent fatigue, unrefreshed sleep. They get up and feel like they really never slept. They often have some depression. They have anxiety. They have irritable bowel syndrome-like things, vague gut things. They often have histories in their past of some sort of stress or trauma, particularly in early life. That's the classic example of a fibromyalgic with a true pain processing disorder. But there are so many other reasons you can be achy or think you have pain all over, and that you have fatigue, and that you have cognitive dysfunction, and maybe you have some gut problems. So particularly if you're a woman, almost any healthcare provider right then and there is going to say, oh, you have fibromyalgia, when that very well may not be the case. And then, unfortunately, a lot of people get given a treatment for the wrong thing because it wasn't diagnosed right. So let's start with fatigue, because that is a big issue in anybody either with real classic fibromyalgia or is misdiagnosed. Almost all of them have persistent long-term fatigue and lack of vitality. And I know there are some great ways to look at that from a laboratory perspective. So you had mentioned organic acids. I use them all the time in my practice. It's probably, other than standard, blood chemistries and CBCs and, the stuff that you have to do in diagnostic medicine all the time, that is probably the most go-to test panel I use, more than anything else, because it tells you so much about so many things. So why don't you talk a little bit about how you work up someone from a metabolic standpoint if they have long-term fatigue?
Okay, so one of the big things we're going to look at, let's first of all go to the organic acids. I know you order it a lot, and we were both involved in writing the laboratory book on it. Organic acids, I think, really can be wildly useful for us in looking at somebody presenting with these issues. So we want to look at their mitochondrial activity. So mitochondria, powerhouse of the cell, making our energy. There are central energy pathways. Are we able to take our carbohydrates, our fats, our proteins, and turn them into the fuel to drive us, our energy currency? Can we make ATP? And so there are a host of markers that can guide us as to whether or not they're actually being, this individual is able to burn fat as fuel. Can they actually usher their fatty acids into the mitochondria and turn those into ATP? It's an incredibly useful piece of information that we can glean readily from an organic acids assessment. Now, can they take their carbohydrates and move them into the Krebs cycle? Some of you might remember that from, high school chemistry. Are there any imbalances in the Krebs cycle that suggest that they're not effectively, shuttling those energy groups, I guess, for lack of into the production of ATP?
So it's taking macronutrients like sugars, fats, things, and protein, bringing them into the cell and converting them to energy. And that's vital to us to have a lot of energy. And many people with chronic illness just don't do that very well, so they never feel like they have a lot of energy. And the organic acid test can take this complicated biochemistry and almost break it down step by step for the provider and give you results on where is the point at which they're struggling. And once you know that, there are things that we can do to sort of repair that problem. So can you just talk a little bit more about what is an organic acid test? Is it a blood test? Is it a urine test? What is it?
So we do them routinely in urine. I think that that's the easiest specimen, and it's just it's an overnight collection, and then your clinician will order it, and then you can mail it in. It's really easy peasy, and it's just information rich for us as clinicians and folks who are fatigued.
So it's a collection over a period of time, usually like 8 to 10 hours, 12 hours, right?
An overnight collection. Yeah. So you don't just you collect all of your urine from bedtime to morning. So if you get up in the middle of the night, you collect that, and then you collect your first morning, and you send that all in. Yep.
Okay. Great.
The other things we might see on organic acids tests that could be useful to us is whether you're making adequate adrenaline, if you're, and we also look at nutrients. And I'll circle back to talking about some of these aspects of the organic acids when we get to those sections.
Right. Okay, what about fatigue from the standpoint of, ruling out, let's say, other medical issues that might be causing fatigue? I mean, you can be anemic, you can have hypothyroidism, you can, there's a lot of reasons for fatigue that don't really involve directly a dysfunction in energy production biochemistry in the mitochondria.
Yes. So arguably, David, and as you know, all of the tests I'm going to talk about today can influence energy status. I think the organic acids are most directly, looking at mitochondrial. That's the most fundamental piece to look at. But really, arguably, any weight on normal function. So any physiological imbalance, if it's extreme enough, is going to impact our energy. So just as you said, thinking about anemia, looking at thyroid function, I look at adrenal function often with a 4-point salivary measurement over the course of the day. I think that can be really useful to see whether or not cortisol is in abundance. We can look at various amino acids to see whether or not they have the ingredients to make some of these energy players we're talking about, B12 deficiency, folate. I mean, there's all sorts of pieces of the puzzle that will impact energy.
Right. And it's amazing how something as simple as ruling out fatigue because of iron deficiency anemia, or like you said, a B vitamin, folate, B12 deficiency anemia, or an overt hypothyroidism. These are things that even a standard orthodox sort of physician should hit their radar screen if they do the test. But I cannot tell you how many people I have come in because they heard me online or read a book or read a piece, a piece that I've written in a magazine or something, and they come in because they know I deal with a lot of fibromyalgia. And when I ask them how they got to, why they think they have fibromyalgia, some of them say, well, I was diagnosed with that by my primary care physician, by my internist, or even by a rheumatologist. And it's a little bit frightening to me, actually, to think how many of those people, when I look back over their workup and their medical history, that these basic tests were not done to rule out these things before they jumped to the conclusion that it was fibromyalgia, when the diagnostic criteria, as flawed as it is, clearly states job number one is to rule out organic reasons, other medical conditions, why they might feel the way they do. And I have to say that it's not uncommon that this stuff is not done.
Yeah. Oh, that's such a brilliant point. I mean, I would say that the most common demographic diagnosed with fibromyalgia are premenopausal women, correct?
Yes.
And now, how many of those women have low iron, right?
A lot.
How many? Yes.
A lot.
It's huge. If you're premenopausal, if you're still menstruating, there's a good chance that you do not have sufficient iron. And it may not show up as frank anemia.
Right.
You may have to look at ferritin, the iron marker, which is, again, very standard, very accepted. But I know you're absolutely right. It's frequently very fundamental investigations are missed.
Yeah, you're right. I've had patients, they've had a complete blood count. They don't have overt low red blood cells, classic in-your-face anemia. I've even had their serum iron look fine, and then you test their ferritin, and it's 2.
Yes.
It's 2, right?
Yes,
so,
I know.
It's not a mystery why they don't feel good, because something as simple as you don't have enough iron in your red blood cells, you don't carry oxygen to the tissues. It's like taking oxygen out of a fire, and the fire, where the fire burns, is the mitochondria, right? So if they're not getting oxygen, they're just not able to do what they're supposed to do, right?
Yes.
And it seems simple, but it's sort of foundational. Same thing with thyroid, right? If the thyroid's not right, it's not telling the mitochondria to operate the way they should. It's sort of the thermostat, right, on all of your biochemistry. And if you turn the thermostat down because the thyroid's not right, everything else is not going to work right. So sometimes we see evidence of problems on an organic acid test, and sometimes it's, a genetic sort of uniqueness of that person. They don't make enough of a certain enzyme, or they make a slightly structurally aberrant or warped enzyme, we call it. But sometimes we're seeing the effects of other issues, like low thyroid, like not enough iron, or things like that. So you really need to, in my opinion, in these complicated chronic diseases, work with someone like yourself, or someone who's really trained in this sort of metabolic functional model that can really look at all these multifactorial things and these different types of tests. Human metabolism is a pretty complicated thing, and someone needs to put all the pieces together for these folks, and that's generally not happening.
And I'll tell you, just as you're hitting home here, we start simple, right? We do absolutely start with those basic panels that are likely missed. I mean, you and I both not only are we doing a careful history, but we're getting the patient's medical records. And if we can't access everything that we need, we'll just, we'll carefully order some very standard panels to rule out these things. And then, we move sequentially. So I'm not going to order 27 tests on you until we move through these things.
Sure.
Okay, let's drill a little deeper. Now it's time for organics. Now it's time for, looking at cortisol levels, et cetera. But, thyroid, iron, all of those are de rigueur, standard investigations, out of the gate for these patients.
And that's a good point, too, because I know how you practice, and your mindset is parallel to mine, which is we don't test for the sake of testing. I mean, we test only if we think it's applicable in that specific case, and if it's something that's likely to change what we do or formulate our diagnosis or our decision making. I mean, you and I have been in practice long enough now. We've seen so many lab tests. We've seen so many patients. There are many tests that might even be appropriate to do, but I don't even have to do them because I've seen so many patients exactly like that. I can clinically tell you what their cortisol is almost, right? Without having to have them spit in a tube. And sometimes I can't, but sometimes you can. I like to tell patients, listen, I need these 3 tests or these 2 tests, but I'm not doing it just because I like to test and I want to make your patient file thicker. I'm going to spend your money like I would spend my money or a family member's money on testing. I'm not going to do it for the sake of doing it, but on the flip side, I'm also not going to waste your time, my time, and your money having you do a bunch of treatments that don't make any sense because I didn't do the right testing to get the right diagnosis. So in the end, I think it is more economical, it's more practical to act on data, right, on objective information. And how many people do you have coming in this week that are walking in with 2 garbage bags full of supplements?
Right. As you say, this
worked.
for that prescribing. That's right. We need to have evidence that a particular nutrient is indicated for a patient. Yep. I know. You're absolutely right. It's just smart medicine. Is it going to actually work in this individual in front of us? Is B12 going to make a difference in their life? Is folate going to actually make a difference? And yeah, I know. I mean, especially since everybody's so incredibly internet savvy. There's many things that a patient, particularly somebody with fibromyalgia who's miserable, is going to be wanting, out of desperation to try. And it is important to have a clinician who can really sort through. Yeah.
And they're looking for the magic bullet, and Lyric is not the magic bullet. None of the drugs for fibromyalgia are the magic bullet. They can be helpful in some cases of true classic fibromyalgia. In many times it's for a limited amount of time, and there are more non-responders than there are responders. But that being said, you can say the same thing about a lot of these nutritional, botanical, these other interventions as well. You have to target it into the right person, and there is no magic bullet. I mean, people can go out on the internet, like you said, and I'm sure they're going to find those old studies on magnesium malate, and that's going to be the cure for fibromyalgia, and it's not. Trust me, it can be helpful in many cases, but it's not a magic bullet. So a lot of times it's a complicated thing. And someone may say, well, Dr. Brady, Dr. Fitzgerald, you're talking about something like anemia, like iron deficiency. How could that cause me to be have pain all over, be tired, have gut problems, have depression? And we're not even saying that any one of those things causes all of it, but something like being anemic. If you can't carry oxygen to tissues, you don't make energy very well. You're going to be tired. Your brain needs lots of ATP and energy, so you're not going to be able to think and have good cognition. Yes. And if you don't carry oxygen to the cells, you go into, as you know, anaerobic metabolism, or you start leaning on other pathways that produce acidic metabolites in the muscles. And then if someone comes and mashes your muscles and does a tender point test, they're going to hurt because the acidic waste product like lactic acid is hitting free nerve endings, and you get a pain response. So you have a lot of pain, you're tired, you can't think straight. You're bound to get a diagnosis of fibromyalgia, especially if you also have an unrelated issue ganging up on you that's causing you to have vague gut problems, like let's say food sensitivity, right?
Right. Yeah, that's right. And I want to move into talking about foods here too. But in the low iron is going to impact gut, because gut is such a high energy organ. So it's not the end all. It's not the answer for everybody, but it's a piece of the puzzle.
Food sensitivities. I've had all of the experts, that do what we do. They all kind of come home to a lot of the same foundational things, right? Energy production, thyroid function, gut microbiota. But food sensitivity is almost on everyone's list because we see it all the time. So
all of the time.
There's nothing we, as Jeff Bland, a mentor of both of ours, has said many, many times. There's no greater influence over your health, and there's no greater way that you communicate directly with your genes than those choices you make every day and what you put in your mouth and swallow into your gut, your food, basically, the macro and micronutrients you consume. So if you're eating something that doesn't work well with your immune response, and you're activating innate immune responses and inflammation and other kinds of more complicated immune pathways, it's not going to be good in the long run. So how do you start evaluating someone's diet and how they might feel from a chronic illness standpoint?
So first of all, it is so fundamental. Food is information directing metabolism of the body. I would say that anybody coming to me with a diagnosis, real or not, accurate or not, for fibromyalgia, I'm going to be looking very carefully at their diet, because immunological reactions to food are, as you said, they're just remarkably common. Right. Even eating even if you're not immunologically reacting, if your food choices are pro-inflammatory, you will indeed push pain. End of story. So food needs to be very carefully investigated. Now, with regard to the actual immunological reactions, I am going to be thinking about food allergies. Does this person have an allergic history that might flag me? There's the classic sort of hive reaction or even anaphylaxis in a severe allergy, but a food allergy could present more subtly, and pain would certainly be a possibility there, or fatigue, or headaches, and some of the other things that we see. So, a true food allergy, is that a possibility? We look at food sensitivities, which is a delayed reaction, and can absolutely present with increased pain, fatigue, rashes, irritability, headaches. I mean, almost, of course, gastrointestinal upset, etc. Food sensitivities, these are delayed reactions. They can happen up to 3 days later. So you eat, if you're reactive to, say, dairy, you eat it on day one, and then maybe 3 days later your gut is upset, or maybe 3 days later your joints hurt. And it's very hard to actually nail down, make the food symptom connection in these delayed sensitivities. And so I do routinely test. You can do elimination diets where you carefully pull out certain foods to see whether or not there's a reaction. You add them in one at a time in a controlled way. So in my patients with fibromyalgia, I'm absolutely doing a careful investigation for foods. I'm looking at food allergies. I'm looking at food sensitivities, and I'm going to look for celiac. One of my, really, I'm going to, particularly if there's a history and there's other compelling reasons, but, one of my first patients at the pain center was on all of the medications. She was on Lyrica, she was on an SNRI, she was on Xanax, and she was on opiates. She was managed on opiates at our pain clinic. And she indeed had celiac. I mean, it was pretty easy. Once I made that diagnosis and we pulled out gluten, her life transformed, as you can imagine. Yeah, that was the fundamental underlying cause of her fibromyalgia diagnosis.
And how old was she about?
She was in her early 40s.
She went all that time. I mean, celiac's not something that happens out of the blue. So she probably had a life of chronic illness and struggling before someone actually connected those dots.
Yes. Well, she was at our clinic, our tertiary care pain. I mean,
pain management.
You don't end up in pain management until you're at the end of the line and you've been suffering and nothing has worked.
Right.
Nothing.
Exactly.
So she was managed on a cocktail of meds. And once we made that diagnosis, we were able to start tapering her off of her medications. And it was a life-changing, really profound event. Wow. She did incidentally have nutrient insufficiencies associated with the celiac malabsorption.
Yeah, absolutely.
So part of her pain was actually not just gluten, but then the associated deficiency in B12. Also, going back to iron, she was extremely low in ferritin. So there were a collection of things that we had to carefully tease out and treat her with, but easy stuff.
Right.
And concurrently, we were able to start tapering her off her medications. Yeah, pretty profound.
And she was just pro-inflammatory. Obviously, she's had an autoimmune disease, an inflammatory systemic autoimmune disorder. So, and was she diagnosed at one point with fibromyalgia along her course?
Absolutely. So, yes, she came to me with the diagnosis of fibromyalgia when I was at the pain center. Many patients came to me with that diagnosis.
It's interesting because I saw a paper recently when I was doing a fresh, I've done so many systematic literature reviews on fibromyalgia, I can't even remember them all anymore because every time I'm asked to write a chapter in a medical textbook, or I have to write a journal piece, or in this case, my new book, direct to the people, the Fibro-Fix, I had to go back again because things change, right? So you have to go back and do a whole new systematic literature review. And in the last one for this book, I found a piece in the literature, a journal publication that actually said celiac disease and with secondary fibromyalgia. And when you read through it, it's clearly one of these cases where the patient had a lot of symptoms that someone might misinterpret as fibromyalgia, but it was really all caused by the celiac disease, right? So I'm always amazed. Why does everyone feel compelled to add on with fibromyalgia or secondary fibromyalgia to celiac disease? It's not fibromyalgia. It's celiac disease, right? Just call it what it is. And those symptoms are to be expected in that kind of situation. You see hypothyroidism with secondary fibromyalgia. It's just a misuse of the whole label. And as you know, I went for years, even decades, trying to publish to my colleagues. So listen, let's stop doing this. Let's diagnose this thing right. Let's not call it fibromyalgia when it's not. Let's fix what it is and call it what it is. So now the case is being taken right to the people because it's sort of, you feel like the boy with the finger in the dike. It's just you just can't hold back the tide.
Listen, people are hearing you. You've done such a service. It'll catch on, eventually among all of us. But I've used your texts in my lectures. You've generated such useful material. I know. Eventually it'll get there. Okay.
So what about other things with the gut? Because we know food sensitivities can cause gut symptoms. They can cause a lot of symptoms outside the gut. But what about, everyone's talking about the microbiome and the GI microbiota and all these bugs that live in the gut and how they can cause havoc and produce all kind of metabolic toxins and inflame us and even inflame the brain. Do you often use some sort of testing, and there are various options out there, but do you look at the GI landscape as far as what's there?
Absolutely. I do. That's one of my most fundamental investigations in folks. It's going to be happening pretty early. I do think gut, dysbiosis, imbalance in the bugs that live there is epidemic. And people diagnosed with fibromyalgia are no exception to that. You can imagine that this celiac patient I just talked to you about, after years of suffering with this profound maldigestion, malabsorption mediated by celiac, she has intestinal permeability. We know that that's fundamental to that condition. And we also know dysbiosis, bacterial imbalance, plays a cornerstone role in celiac and how severe it might express. So I'm definitely looking at that interface between the gut bugs that live in our gut and our immune system, and also the gut mucosa, digestion, absorption. All of those are incredibly, incredibly key investigations. And as you just mentioned, you alluded to this idea of the gut-brain axis. Right. We know that, these bugs living there, they can either directly make some of these neurotransmitters that are problematic in fibromyalgia, they can directly produce some of these, or they can stimulate us to make them.
Or they can suck up precursors, like in the case of certain bugs consuming all the tryptophan, right? Or changing those enzyme pathways so you don't make enough serotonin. And one of the big things with true classic fibromyalgia is a deficiency of serotonin.
Exactly. So myriad mechanisms can implicate the gut in fibromyalgia. And there's just no question we have to look carefully and correct what we find. So stool testing is common. Sometimes, in yeast, just an overgrowth of garden variety candida. If somebody's got a history of a lot of antibiotics, if they've got a history of having used steroids, if they've been eating tons of sugary foods for a long time and crave sugary foods, there's going to be clues for me. Do they have toenail fungus, or do they, just various clues? Do they have a very white tongue? Certain things are going to flag me to thinking about yeast with folks. And we know that yeast, even gut, even bacterial overgrowth, they can produce things called endotoxins that can be absorbed systemically and cause the pain that you're talking about, cause irritability, headaches, anxiety, all of what might be misdiagnosed as fibromyalgia. So there's I think that looking at the gut is extremely important.
Yeah, when I was doing my interview with Dr. Jacob Teitelbaum, he was talking about the yeast connection and the endotoxins just like you were. And there's a greater appreciation now on dysbiotic organisms of all types, whether they're bacterial or fungal or what have you. They're producing metabolites and they're sort of throwing out their waste products into our gut. We can pull them up. And some of those things can get to the brain. And what's interesting is new research in true classic fibromyalgia, particularly research out of Mass General and Harvard, showing that even though we've known for a long time that fibromyalgia is not inherently like an inflammatory, systematic inflammatory disorder. You don't get like elevated SED rates and C-reactive protein. It's not like an autoimmune, inflammatory arthritis or something like that. But when they look deep in the brain, there is inflammation of the microglia within the brain itself. And perhaps the brain is sort of on fire, right? So you get this brain and deep-seated brain pain. And that's sort of what fibromyalgia acts like, right? It's deep in the brain with limbic system dysfunction and aberrant pain processing and failure of descending antinociception. And it's starting to answer why certain agents may actually be effective, like, for instance, low-dose naltrexone is now being used in fibromyalgia. And opioids generally, as you know, don't really work in fibromyalgic type of pain, true fibromyalgia pain. But low-dose naltrexone does. So there was always like, well, why does this work if it's not along opioid sort of metabolism? And it turns out that low-dose naltrexone, of course, is a pleomorphic agent. It stops microinflammation, as does vitamin D, by the way, which is used effectively for pain also. So we're learning more and more as we go, and maybe inflammation is part of even classic fibromyalgia, but just at the microscopic level inside the brain.
Yeah, so, I think that just makes very, very good sense. I mean, it rings true to me, and we see that microglial promoted inflammation, that what we call glutamatergic excitotoxicity, and other conditions as well, like autism and even some neurodegenerative conditions like
ALS and things like that.
But, really important work. That's great.
What's really interesting is, in fibromyalgia, classic fibromyalgia, sort of the real deal right down the line, diagnosis, it's almost 100% comorbidity with what we would call irritable bowel syndrome or functional bowel disorders, and a very high correlation with something like small intestinal bacterial overgrowth. So we know those connections are absolutely there.
Wow.
And I wrote chapters on that specifically in Dr. Jerry Mullen's book from Johns Hopkins, Integrative Gastroenterology, on that connection between central pain processing disorders like fibromyalgia, IBS, and SIBO. So testing along that gut axis is absolutely essential.
Yeah, gut-brain axis. Yeah, and so I'm talking about stool testing, but just to go back to SIBO, as you just mentioned, of course, we can look at that with breath test. And even, the organic acid gut markers
they do.
Can be reliable. Yep.
There are at least indicators to maybe consider a breath test, or maybe go to stool testing if you're getting those what we call dysbiosis markers on the organic acid test, and if the clinical symptoms seem to line up with the patient. You had mentioned, though, before testing for nutrient deficiencies, and I know that just looking in blood, like a standard blood test, is not really that instructive to us on nutrient deficiencies. It can be in overt cases, but a lot of these nutrients, we're worried about what their levels are functionally inside the cell and what they're doing metabolically, not what's floating around in the blood. So how do you look at nutritional insufficiencies, even if they're not overt deficiencies, insufficiencies?
So that's another great question. And, just sort of piggybacking on the gut, maldigestion, malabsorption, so widespread. So probably we're going to find in this patient population some evidence of inadequate nutrients, but we want to accurately assess for them, like you said. So I think, pretty straightforward for minerals. Well, we know ferritin is reliable for iron. That's demonstrated. Or you can do a full iron panel. But, if we want to look at magnesium, zinc, potassium, selenium, et cetera, I think a useful way to do that is by actually looking in the red blood cell. It's almost like a tissue sample. So it's almost, it's correlative to what's happening.
It's like a 120-day window into your metabolism. Almost,
Red blood cell. And the cool thing about that is that we can get a lot of these red blood cell tests covered by insurance, these red blood cell mineral tests. If your doctor's looking at serum or plasma, those are not as reliable. So your potassium that you've seen in your chemistry screens that your doctor orders on you annually, if it's very low, well, it's a big problem. And you probably have leg cramps.
If you want your heart to beat,
Exactly, right.
Only if you want your heart to beat.
Fundamental, But a more subtle deficiency is going to show up in the red blood cells, and the serum is just going to tightly regulate it, and you're not going to see the kinds of deficiencies that we're talking about. So red blood cells, awesome for minerals. Looking at vitamins, serum is okay, but, just like you were saying, David, a serum B12 level isn't going to tell us it'll give us some information. It will tell us that we can actually absorb B12.
Right.
That's what it's going to say. If you see it there, if you're taking B12 orally and you see a high B12 in serum, then yes, your body's able to absorb it. And that's actually a pretty good piece of information. But it's not going to say, is it getting inside the cell? Is it doing what it's supposed to do? One of the great markers, coming back to the organic acids, is methylmalonic acid.
Right.
Fabulous.
And you can get it on a blood test too if you order.
You can,
Right.
but here's the caveat with this. Super important for any clinicians or patients who are going to ask their doctors to do this. The standard labs that we go to for these are set the reference ranges so far out.
You have to be so aberrant to.
Got to be so abnormal. Yeah, 3 standard deviations. That means that I think 0.01% of the population will actually be labeled as high.
Right.
Normal labs set at 2 standard deviations, so maybe the top 2.5, will be high. And so, not to get too complicated, but methylmalonate ordered from a regular, laboratory that you walk into on the street here is not as useful.
So you have to look at it within the context of the entire reference range, not just does it have an L next to it, or in the case of methylmalonic acid, an H, a high next to it.
Yep. So you could look at mean cell volume, which I'm sure that you've talked to or you've written about, is the cell size. We talked about it at the beginning. Is your red blood cell size so large that suggests a B12 and folate deficiency as well? But go ahead.
That would be macrocytic anemia, essentially.
Yep.
Right.
Yep.
Right.
Yep.
How about toxins? Because, you mentioned before these metallotoxins, and mercury, for instance, is extremely problematic because, these transitional metals, as they call them, glob onto our host proteins, right? And to the sulfur groups on our proteins. They fundamentally change them. Yes. They turn them into what we call haptens, and the immune system reacts against them, number one. So it can be immunogenic. But on the other side, they can really do the same thing and glob up and cause enzymes to be dysfunctional. And mercury, for instance, we know it really messes up energy enzymes, right, in the mitochondria, but also conversion of thyroid hormones, things like that. So it can really, fatigue is a really common complaint in people who have high levels of mercury and lead and other metals. Do you agree and see that?
Yeah, I absolutely do agree. And you might see that lactic acid buildup if your Krebs intermediates, if you can't make energy adequate, just like you said, that whole anaerobic metabolism and pain associated with that. Yeah, so mercury toxicity, I look for it. And again, I'm taking a careful history and evaluate for it in blood or in urine. But I just want to give you a quick case on this topic. So yet another patient presenting with, what we might call fibromyalgia. Her primary issue was anxiety, just overwhelming anxiety. She was a young woman. She's in her early 20s. But when I took this in, but she also had pain issues, musculoskeletal, joint and muscle. I mean, she certainly wasn't classic fibromyalgia, but she was sort of potentially in there. Her history was extremely significant for the fact that her mom and she, in their efforts to eat healthy, had actually loaded their freezer with Chilean sea bass, one of the most mercury toxic fish on the planet. Seriously. I mean, I appreciated the fact that they were really trying to eat healthy, but they had chosen to eat, multiple times a week sea bass for, months. And she presented to me with just full-on anxiety, pain, just a handful, some hair loss. And so clearly I needed to look at her whole blood mercury. Whole blood is going to suggest current toxicity.
Ongoing toxicity. But what about those people with...
it was really high.
What about the people with burdens that go way back? Is it?
So then you want to look. Okay, so whole blood is good for here and now exposure, like this individual, and then urine. We're going to look at urine is I think the most useful. And we might so urine is so the body sequesters these toxic metals quickly. They're moved out of the blood into fat, into bone in the case of lead. And remember, our brain is 70% fat. So we're vulnerable to accumulate.
People call me fathead. I say thank you.
I know, right. So we need to look at another specimen. Whole blood's not going to be reliable there for anything of long-standing duration, and so I tend to use urine metals. And
do you use a provoking agent like DMSA or N-acetylcysteine or something like that?
Here's my protocol. If I do provoking agents, as you've just outlined, first of all, you just have to demonstrate kidney function is good, so they can move it out. But I do a baseline non-provoked, and then I'll provoke and see what's happening, see how much they're dumping. And, the other piece of this, if I'm looking at longstanding body burden, before I'm going to go in there and treat it, if I identify it, I want to do all of the stuff that we've talked about. Are they, having regular bowel movements? Are their nutrients up to snuff? Is mitochondrial health good? I need to dial them in, functionally, so that if we do identify a body burden, and if we do start to chelate them, they can actually get the stuff out. So there's a process to moving out metals when we identify metals as an issue, an important process. We don't want
metal detoxification, chelation, and all those things is sort of an art form. It's a whole interview in and of itself. And really, if you're going to get into that arena, you really need to work with someone who knows how to do it.
Right. But acute mercury toxicity could be potentially mislabeled as fibromyalgia.
Sure,
I just wanted to put that out there, given that one patient case.
And we're getting short on time, but I wanted to touch on stealth infections, particularly you practice in Connecticut, I practice in Connecticut. I see an epidemic of Lyme, tick-borne illnesses, but I also see a lot of chronic viral infections, things like that can make people, feel achy, feel tired, and just not have a good state of health. I mean, think about when you get the flu, right? A viral infection, it's acute, granted, but, you're tired, you're achy, you can't think. I mean, so if you back that off a little bit, but it becomes on a chronic basis, you can quickly see how sort of a stealth smoldering pathogen of some sort can cause a lot of these kind of symptoms. So how do you consider that?
Well, I mean, obviously, yes, as you said, we're both in Connecticut, so it's going to be high up on our list to want to rule out.
Right.
It seems most of our folks have been exposed to Lyme or a Lyme co-infection, and it's probably going to be fairly early on that I want to rule that out. So we can go through, there's the standard labs that we can get insurance coverage on that I often start looking at, just a Western blot from a standard lab.
Right.
There's also, we can get ideas of inflammation. Sometimes I look at active vitamin D. We've talked about that. That's a little bit tricky, a little bit less research around that, but 125 vitamin D. Mm-hmm. Sometimes I look at a marker called CD57 or complement protein C3A and C4A. So those are things I can get insurance covered easily that are going to give me a hint of an idea of whether or not I'm dealing with Lyme or chronic Lyme or co-infection or even mold toxicity. And then if I need to go and make a more careful investigation along that line, there are specialty tests that I can order that will give me more reliable evidence.
Do you use more of a DNA molecular hunt for the pathogens, or now there's testing that looks at the changes in cytokine expression and immune, uniquenesses of the immune response that are novel to Lyme or to Borrelia, organisms?
So, okay, I look at DNA. I look at, there's a lab out there that's doing a more reliable Western blot. I've relied on those. In the case of mold, I'll look for mycotoxins in the urine. So the cytokines associated with Lyme disease, I have to say initially I wasn't really excited about what I was seeing with that particular test, but I do think that they've evolved, and I do think that some of what they're seeing there now is reliable. And I think it can be a useful tool in the investigation for occult infections.
So a lot of people have probably seen some of those tests, like IGeneX testing. They do some interesting stuff with DNA, molecular, but also, like you said, more comprehensive Western blot type of testing. And then you have labs like Pharmason or Cyrex. They do some other things as well, including that iSpot Lyme test. And I think they all have a place, and they all are useful, particularly if you're really trying to work that up. What about the final thing is, what about genetic testing and fibromyalgia? Is there anything that you are aware of that can be helpful there?
Well, so we've gone through a lot of testing options, and, I would say that genetic testing, for instance, if you have an issue metabolizing your neurotransmitters and they're either rapidly turned over, we know serotonin is a fundamental issue in true classic fibromyalgia. dopamine imbalance, epinephrine, norepinephrine, et cetera. All of those things, we can have genetic mutations that might alter those neurotransmitters in our brain. There's plenty of genetic mutations relating to our ability to detox, chemicals, metals, et cetera, hormones. Of course, everybody's probably aware of the methylation issues that we can have. So I think that there can be a place for genetic testing in this patient population. It's not necessarily going to be something that I immediately go to, but I'm aware of it. I do it. I use it when I think that it's appropriate. And as you said earlier, it's going to, influence what I'm doing with the individual.
And it's not necessarily a genetic test that's positive in a classic fibromyalgia, but it's giving us ideas metabolically on why they may be having problems leading to fatigue and pain and
Correct. Right. That's exactly right. And so it's appropriate that it's at the end of our interview, because that's really I'm aware of that, and I do pay attention to genetic involvement and things, but it's not a first line answer. It's not. We have to move through in a very intentional way all of these areas that we've talked about.
Right. Okay, great. Well, wonderful information. I know that one of the things you're going to be doing for me for the Fibro-Fix Summit is kind of putting together a little bit of a list of a lot of these tests we talked about, because, most of the people watching will not be doctors or healthcare providers. They're people interested in it probably because they're either struggling with a condition themselves or a loved one is, or so forth. So having a list of some of these test possibilities will be very valuable, and I think you're going to be compiling that, and the summit will provide information on how they can actually get that from you.
Yes. Yep. I really look forward to that. So a list of what I'm thinking about doing that you can print out and bring to your functional medicine doc or your doctor and your regular doctor and talk to them about that.
Great.
Some good ideas.
So before we, sign off today, can you just tell the listeners where they might be able to learn more about you and your work? And I know because you do such great online content with your blogs and your newsletters, and you do them both for patients and for healthcare providers, which is extremely valuable. So.
Yeah, so it's easy. It's just drkarafitzgerald.com. Kara, Kara, Fitzgerald, Fitzgerald.com.
Great.
So come on over to my website and check us out. I hope you like it.
Awesome. Yeah, I highly recommend that they do. And thanks again for being on. This is Dr. David Brady, your host for the Fibro-Fix Summit and author of The Fibro-Fix. Please make sure to click either on the side or below if you'd like to take this content home with you. And if you have some people you'd like to share it with, perhaps you know somebody struggling with chronic achiness and pain and fatigue, and maybe they've been diagnosed improperly or not with fibromyalgia and would benefit from this information. So thanks again, Dr. Fitzgerald.
Thank you.
Okay,
Great
bye-bye.
to talk. Bye-bye.